Hello, good morning, good afternoon. I'm Gabrielle Bennett and I'm a clinical nurse consultant and one of the Victorian viral hepatitis educators based at St Vincent's. Our role's funded by the Health Department to provide professional development on viral hepatitis. So today I'm going to be talking about strategies that you might be able to do in your practice to increase screening for hepatitis B and hepatitis C. I'd like to start by acknowledging the traditional owners of the land that we meet on today and acknowledge that this land has never been ceded. To put that into some context for today's topic, we know that Aboriginal and Torres Strait Islander people share a very disproportionate high burden of both hepatitis C and B. So it's particularly important that we think about how accessible our services are to these communities. We've got lots of project partners. So the objectives for today, I'm going to go through a little bit about cultural safety and how to provide an inclusive environment for your clients, talk about different strategies that might help you to increase screening, talk about the different roles and responsibilities in your general practice team around increasing screening, and give you some lists of great evidence-based information that will help you to do these things. So most liver cancer is preventable. We know that the primary prevention for hepatitis B is the vaccine, which is fantastic, effective and safe. There's no vaccine for hepatitis C, and so we need to prevent it by using harm reduction strategies, like providing clean injecting equipment through needle syringe programs, for instance, and reducing stigma also has a really important role to play. Secondary prevention includes diagnosing and treating people with chronic Hep B and diagnosing and curing people with chronic Hep C before they get cirrhosis. Mortality from liver cancer can be reduced, and liver cancer surveillance is really important for people with cirrhosis or people who meet the criteria to have regular surveillance. So first off, I'm going to go through some enablers for creating a culturally safe and inclusive environment. So when I talk about culture, of course, we're talking about ethnicity, which is particularly relevant for people living with hepatitis B, but also about peer group culture. So there is a culture of people who inject drugs, people who might be experiencing homelessness. Yeah, they have a common understanding. So we're taking a very broad perspective of culture. So as Beck has said, we've got 77% of people with chronic Hep B not in care. That's a huge amount of people. So we want to think about how we can increase that and how we can get these people involved in their own healthcare. We've treated and cured about half the people who are living with hepatitis C, so we've done very well over the last 5 years, but there's still a lot more people that we need to engage, and they're probably people that have more barriers to actually accessing treatment. So understanding these barriers and enablers will help us make improvements. So what is culture? Culture is a very complex thing, and it could be, you know, the way you look, the clothes you wear, the language you speak. They're things that we can see and can sometimes make a judgment on or an assumption. But there's a lot about culture that's invisible. So things like health beliefs, our attitudes, our core values, how we relate to people. These have a very strong influence on our interactions and our communication, and they're not always visible or easy to understand. Cultural influences on our health beliefs and behaviour are many. So, how we share information, how we receive it, how we respond to treatment, whether we access healthcare, all these things really make a really big difference in how we engage with our healthcare. So often we talk about these sorts of issues for the patient or the client, but it's also really important that we think about the healthcare worker and our cultural influence. We often don't consider these things, but we need to reflect on our own beliefs, our own biases, our own behaviours, and reflect on our unconscious bias that we all have in the way that we respond to people. For instance, I worked in women's health for many, many years. When I went back to working with male patients, I needed to really adjust the way I thought, the way I worked. It was an unconscious bias, I guess, in the way I spoke with people. So that's just an example of how you might need to reflect on your own communication. So this little meme is about communication and how can we minimise understandings. And you can see that the 5 different people here are all communicating in a very different way, and these ways of communication are often culturally prescribed. So some people want more personal space, some people, need to produce a little card, some people aren't sure whether to shake hands. So we need to check back with our patients and ask them for direction if we're not sure, and think about how is the best way to communicate with them and how are they going to communicate with you. Many clients will be uncomfortable to ask you questions, so you need to give them space to actually do that and have a conversation. Culture is particularly important to chronic hepatitis B, and you can see on this graph the people living with chronic Hep B in Australia. So starting in the dark blue, up in the 1 o'clock, 2 o'clock area of the pie, we have people born in Northeast Asia, 23%. And then we go round, people born in Southeast Asia, people born in Europe. We can see that about 2/3 of people living with chronic Hep B in Australia were actually born outside of Australia. So this may influence a lot of things in the health consultation. Do they need an interpreter to help with language? Do they have a preferred gender of their healthcare worker? What's their preferred method of communication? I'm going to show a short video now. This is from the Hepatitis B Foundation in the USA, and Alan is going to share his story. It just goes for about 3 minutes.
When I listen to my son sing, I just wrap myself around that moment. Somehow it takes me back to all the memories, the beautiful experiences my uncles and so many others never had, simply because they didn't know. Uncle Peter passed away in his mid-50s, then Uncle Luther a few years later, and it eventually caught up with my Uncle Henry in his 60s. My family only knew my uncles died from liver cancer because doctors never say a person dies from hepatitis B. So we didn't know what was killing us until around the time I met Jill, who became my wife. My liver became so badly inflamed that a doctor finally diagnosed me with the chronic form of the virus. It was only because I was an anchor and news reporter with a medical reporter friend who connected me to a leading hepatologist that I got the attention I needed. Only then was I asked about my family history and encouraged to talk to my family and begin treatment. Later, we found out my older brother and sister had been rejected at the blood bank because they had Hep B. Then my mother and younger sister decided to get a blood test. They had it too. We were left to connect the dots because the medical profession is failing to address an epidemic that kills more than 700,000 people a year. It's bad enough that hepatitis B is a silent killer with few symptoms until it's too late. It's also ignored by Asian cultures that consider talk about deadly diseases to be taboo. Sometimes I wonder if hepatitis B is being ignored here in the U.S. just because it impacts so many Asians, especially given the country's history of discrimination toward immigrants. I think about that a lot. I also think about the millions of other people who could lose the same joy I have because they simply don't know they have the virus, and about how lucky I am that my early treatment gave my liver a chance to regenerate itself.
No hands! I'm not holding you! You're on your own, kid!
We're not just trying to cure cancer, we're trying to prevent it before it happens. The biggest battle is against ignorance amongst patients and doctors. We can do this. Just be proactive.
So even though Alan's story is based in the USA, I find that there's a lot of similarities to people's experiences here in Australia. So Alan talked about the stigma involved with having hepatitis B, cultural taboo around not discussing hepatitis B within the family. He talked about racism, and there's certainly a very strong history of that in Australia. He talked about inadequate information from doctors and nurses and health services, so people don't actually understand what they need to do. So I think it's really important to think about all those things with our own clients. And this is part of the reason we have 77% of people with Hep B not engaged in healthcare. Culture and inclusion relating to hepatitis C is quite different. And while there might be ethnic, cultural issues for sure, there's also a very strong factor around the criminalisation of drug use and the social discrimination of people who inject, people who are drug using, and that is, you know, about 80% of people with Hep C have used drugs at some point. So the criminalisation and stigma really create huge barriers to healthcare. You know, people who inject will often have their own culture, a bit like a workplace team or a football team. They sort of develop their own culture. And, you know, one way you can combat this is being open to drug use and not judging people, having signs in your rooms or your waiting areas about needle syringe programs so that people get the message it's okay to talk about their drug use. Now I'm going to show another short video about hepatitis C, and this is made by Eliminate C Australia, and they've run a health promotion project called It's Your Right as a way to try and get the message out to people that it's their right to have their hepatitis C cured.
When I was young, it was kind of it was part and parcel with just being creative and angry Gen X, you know. All your heroes and your the stars were, everybody was taking heroin, so of course you did.
Using drugs from the age of 12 and not realising at the time when you start taking drugs what it's going to do to your body and your organs, etc. Then becoming a mother myself and having to look after not just myself but another human being.
It was a shock. When I first found out I had Hep C, it was a shock. I sat down and worked it through, and it took 14 months from start to finish. That was going to jail in between times, 3 fibre scans, etc., etc.
A good friend of mine and a colleague actually died from Hep C related liver cancer. It wasn't sort of, I guess, until then that I saw the real implications of what long-term, like chronic Hep C, can do over time.
For people that are hesitant of doing the treatment for one reason or another, I think you should go and take a chance and do the treatment. You've got nothing to lose whatsoever. You don't have to stop your drug use. I used all the way through my treatment.
Just to know that there are peers out there, other people just like you who have had Hep C, who are either currently using drugs or have used drugs, that are there that do the same thing. And you're more than able to go and talk to them and get them to help you if you need help to navigate the system. And most of us do.
I work as a peer worker. I work for the the state drug organisation in New South Wales, and I've been doing that for a number of years. And other peers like myself, we go around and talk to people. We don't judge. I've had Hep C. I used to take drugs. I understand. I've been to prison.
A lot of people ask if I was depressed before I'd done the treatment, and when I really think about it now, I was depressed. I used to just stay home all the time.
We should be looking after our health better. You should be going to see a GP at least once a year, probably more often, but when you do, ask them to do a Hep C test.
Each time you do have Hep C for any kind of period of time, it's doing more and more damage to your liver.
If you know that it's there and you're doing regular tests and you know you've got Hep C, we can cure it. 60 days we can cure it. And then if you're still using, or for some reason something goes wrong again, we can do it again, and that's your right. You need to be healthy. You have the right to be healthy in this country. We have a great health system, sometimes a bit under strain, but it's still a great health system, and we should take advantage of that.
It wasn't just that I've cleared the virus, it was how my body, my mental state felt. I felt so good. I wasn't lethargic, I wasn't depressed. I've got a full-time job now. I'm not staying at home just waiting for payday. And I feel like a new person, or like a bunch of bricks has been taken off my shoulders.
And never stop expecting better for yourself.
All it involves is taking one tablet once a day for 12 weeks, or 3 tablets once a day for 8 weeks.
Because as we get older, all these other things are just going to get worse. And we can get rid of this one in 90 days, 90 pills. It's clean, it's finished. Why not fix something when you can?
Make yourself feel better.
So you can see from these people's stories, that their experiences were that everyone was using drugs. People had been in jail, feeling depressed, not working. They had friends dying. It was very difficult for them to navigate the health system. There's many issues there that create barriers. Now we have this great opportunity to, have an enabler to make hepatitis C cure so much easier. A lot of these people with Hep C that have not been treated are probably fairly marginalised and may have had some bad experiences in health services. We know that many people have. They've experienced stigma and judgment, so they don't really want to access a health service. They're scared that they're going to be judged. So there's all sorts of opportunities there for the way we interact with people to make it easier for them to get tested and treated. So some of the challenges for the clients, we've talked about navigating a complex healthcare system, which is getting more and more complex. Sometimes I find it difficult to navigate our health system, so I can't imagine how clients feel. Stigma and discrimination are alive and well for both hepatitis C and hepatitis B. Things have improved, I think, over the last 5 to 10 years, but we still know that many people do experience stigma within the health system. Language barriers are still very prominent, and we need to be offering people interpreters, even if their English is good enough to say hello, good morning, how are you? It may not be good enough to understand the complexities of viral hepatitis. Socioeconomic disadvantages are a growing thing in our communities. Unfortunately, we have more and more people that are experiencing poverty. So some of the clients that I worked with lived in areas on the outskirts of Melbourne. There was no public transport. They didn't have buses. They might have had 3 children to look after. To get to an appointment in the city or even, 10 kilometres away was incredibly difficult challenge for them to manage that. So, these socioeconomic disadvantage really impacts whether people can access healthcare. Many people have had past negative experiences in health services, and I think of the refugee communities that I've worked with. Some people had in their countries they came from, had experienced torture and prison within health services. So they can have a lot of fear when they're accessing hospitals and health services. Poor health literacy is very prominent in our community, and we know that about 60% of people have inadequate health literacy. They're not able to negotiate and to navigate the health system to improve their health. So it's really important that we use very plain language, avoid jargon. We need to use short sentences, and really importantly, we need to check what the client's understanding is of what we've just said. So using techniques like teach back and chunk and check are really important. Often what we think we have said is not what they've understood. Now for some challenges for health services. I'm sure you're all very aware of these challenges, and you could probably add many to the list. Time is increasingly a problem for health services providers in primary care, and many will say that the financial support from the government is inadequate. Unclear referral pathways, they're getting more and more complex, but luckily we have some very clear referral pathways for Hep C and for Hep B, which I will note later. Limited feedback from specialists. I know many GPs are worried about being audited for Medicare, and sometimes this can discourage them from ordering particular tests or services. Many say that they can't access interpreters when in fact they can. The telephone interpreter service is a Commonwealth service where all GPs can access interpreters for free, and you can actually pre-book interpreters through that service as well. So lacking knowledge of cultural practices and health beliefs, we can't be experts on every cultural group that we're working with. So if you're not sure, ask people. I find that people actually are really pleased to be asked about their culture, about what suits them, about what works for them. There's a lot of information around about health literacy and how we can be using the principles of health literacy to ensure that our clients have actually got the information and knowledge they need to be actually able to engage in their healthcare. And again, I'll give you some links at the end of this talk. Now I'm going to talk about the principles of inclusive healthcare, and the Department of Human Services in Victoria defines primary healthcare inclusive practice as being person-centred, quality healthcare in a respectful environment. While we all try to do that, I'm sure there's all sorts of barriers sometimes to us actually being able to do this. So we need to, in a practical sense, think about how we can empower clients, how we can increase access and engagement and their participation. So there's a lot of information here about how we can change things in our practice. I'm not going to go through them all, but these things don't usually just happen. We need to actually discuss them within our teams. We need to plan for them and think about who's going to implement them, and to be creative in the way we do that. So staff trained in greeting and responding, well, that might sound really simple, but I still see in a lot of health services that staff don't introduce themselves, they don't say their name. Just saying your name and what your role is can be a really simple start to this. I think having posters and symbols in waiting rooms can give people messages that they are welcome, that you understand the needs around interpreters or culture, or you understand that people do use drugs. Having symbols around needle syringe programs, interpreter services can be another very simple way to start getting the message out to people. There's a lot of information on how we communicate, the language we use. So making sure our forms are up to date and include relevant titles and genders. Down the bottom here, there's some links to some great programs. Drop the Jargon is a program that was started actually by a GP who realised that her jargon worked really well with her colleagues and her team, but really didn't work well with her clients. So it was about the challenge of her starting for a day not to use medical terms to her client. And this can be quite challenging because we're used to using our jargon. And it takes practice. So there's a campaign now about Drop the Jargon. The Teach Back toolkit is another resource for you. Teach Back is a simple communication technique where we check back with the client that what we have said, how does it compare to what their understanding is? So instead of saying, do you understand? People will usually say yes. What we say is, can you tell me in your own words what you're going to do with these tablets when you get home, for instance? And you'll learn that people often don't understand the information they need to. Language Matters and the Power of Words are two resources that were developed by the Australian Drug Foundation and other services. And they talk about how the words we use give messages. So people might talk about addicts, for instance, or they might talk about junkies. These words give clients a very powerful message and that they're going to be stigmatised. So I think thinking about how we use language and being really objective, talk about a person who uses drugs. There's no stigma or taboo attached to that. It's just what it is. It's objective. So practice enablers continued. I still see some paper files with red alert stickers on the front. People see those stickers and, it really puts them off. I still often see lists of clients' names on desks. I think, confidentiality is something that we need to be constantly, I know I do, I need to be constantly aware of it and improving the situation. Referral to inclusive health services and specialists. So think about if it's difficult for clients to get to services, can you refer them to a service where there's a number of services? For instance, in community health centres, you might get a GP, a dentist and a physio all in the same service. You can bundle the appointments together. Consider the need for supported referrals. So a lot of the clients I've worked with might need some help. So as a refugee health nurse, I actually had to go to medical appointments with many clients because they didn't understand the system. They didn't understand what they were told. That was, you know, a supported appointment. You might offer them the telephone to actually ring up and make an appointment right now. Trauma-informed care is really important. Many people with Hep B and Hep C have had traumatic backgrounds and been treated very badly. So we need to be aware of that and be careful not to re-traumatise people. There's a lot of resources around to help you. Down in the left-hand corner here, this is from the Eliminate C toolkit, which I'll give you the link for. There's all sorts of information in there about what you can do in your practice to improve hepatitis C care for patients. Starting the conversation. Some people find this awkward. There's all sorts of suggestions there about how to do that. This photo is from a GP practice utopia in Hoppers Crossing. They have some cultural symbols. They have a bag, some artwork, a shawl around the rooms. This immediately gives their client group information and a message that we understand a little bit about your culture. We're happy to work with your culture. Checkups for hepatitis B. This is a checklist that you can use when you're talking to people about their checkups. It suggests plain language and uses lots of images for people to give them the message if they can't read or understand the words. That's available through St Vincent's, as is the hepatitis B story, which is very big on images and very low on words for people with low health literacy. That's available in 12 languages and also in video format for people who may not read their first language. This brochure was made by Harm Reduction Victoria. A tablet a day makes Hep C go away. Very simple, plain language information with graphics. It gives the message very quickly. So these are just some of the resources. There's really a lot out there to help you. Now we're going to talk a little bit about effective strategies to increase screening, and we're going to talk about patients at risk who need to be tested, people who have been tested but not diagnosed. Well, they may have been diagnosed, but they don't understand what they need to do with that information. We know there's many people that haven't had the sustained virological response test at 12 weeks after cure of hepatitis C. And we know that there's a lot of people that still require ongoing care even after they have been cured of hepatitis C because they have cirrhosis or they fall into a HCC risk group. The EC Partnership tool also gives information about patient management system searches, and these can help you very quickly look at your patient group. You can get some really important data from it very quickly to help you think about how you can improve care to these communities. Conducting audits can be very helpful, and the tool goes through this using PenCAS about how you can very quickly pull up who your client group is and look at, you know, what their latest test was, who hasn't had follow-up care that might be needing it. PenCAS can also help you do an audit on hepatitis C, and again, it's all just step by step in the EC framework. Recall and reminders, reminders can really help with people to remind them. Of course, if you're going to do SMSs or text messages, you need to think whether your clients have got mobile phones, whether they've got credit on their phones, whether they're going to understand the message. GoShare is a app that you can get. I think it could be part of this bundle from the PHN. What it does is it bundles together different resources electronically so that you can send them straight to your client. Of course, they need a mobile phone, they need internet access, and they need private space to be able to read it. And I find that many clients don't have that. However, many will have that. So it can be a very handy way to get information across to your clients. Supporting opportunistic screening is really important. Conversations need to be held, at every opportunity you have. And it could be as simple as saying, I know a practice nurse who just decided that for 1 month she was going to say to everybody, we're offering everyone Hep C tests this month because now we can cure it easily with tablets. Just making a statement. Some people followed up with that. They were interested. They wanted more information. Other people didn't. But it took her probably 10 seconds to say that. It actually opened up the door for many more people to be screened opportunistically. Obviously, providing clients with education, websites, links, and adding notes to your client files can really help. Now we're going to talk about the roles and responsibilities of the different people in your team. It really does require a whole of practice approach. Jack Wallace at the Burnet Institute and his colleagues have done some research and a paper on this and found that a whole of practice approach is really what works. So it's about GPs, managers, practice nurses, bicultural workers, administration workers, non-medical staff, all knowing what their role is and how that feeds into the team. It's really important to have a person who has a nominated portfolio to drive community engagement, to drive cultural competency and relationship building. You really need to have a clear plan in place, and it's going to require discussion and require some creativity. So questions to consider. I won't go through every thing here, but for instance, displaying hepatitis screening and cure materials in your practice. Who's going to do that? Who's going to source them? Who's going to pin them up? Simple things, but things that can really make a difference to your team. Do you have visual cues to demonstrate cultural safety? So a lot of practices I see now might have the Aboriginal and Torres Strait Islander flag on the door or up on the wall. They might have signs about interpreters. We're happy to use interpreters. They might have the LGBTIQ flag in a prominent position. So people immediately get the message that they're welcome here. There's a lot of information here about roles and responsibilities, and I'm not going to go through it all, but we'll pick out a couple of things. So using welcoming and inclusive language, asking the question about people's ethnicity and whether they're Aboriginal or Torres Strait Islander immediately gives them the message that it is important to them. We've talked about using plain and inclusive language, and I can't emphasise that enough. It really is important to be able to engage people in care. Ensure that results are added to your clinical software. I know that in some software systems, you might have about 3 or 4 different descriptors for hepatitis B. So, it could be HBV, it could be hepatitis B positive. There's different descriptors there. So if you decide in your practice just to use one descriptor, it's going to be much easier to do your audits and to, pull up your information very quickly. Responding to recall or reminder systems, if you get that all automated, that can make a really big difference to people. Discussing hepatitis risk factors, screening and treatment with people, offering interpreters at the appointment, even if people do speak good English, enough to say hello, you can still offer it to them. So identifying where you can access evidence-based information and training. There really is a lot of information out there for you, so please access it. Most of it is free. The Eliminate Hepatitis C Partnership, run by Burnet and many other agencies, have developed a practice support toolkit. Here's the link down here. It can help you work out your audits, to set up processes for follow-up. It can help you to have conversation starters. There's little posters in there that you can pin up in your waiting room. It's a great resource, and many of their suggestions also work for hepatitis B. It also talks about how to optimize your patient management systems by setting up shortcuts, improving the quality of your records, streamlining your reporting. Melbourne Health Pathways is a great initiative that the PHN, I think, still facilitate that. You can just click on chronic hepatitis B and a whole pathway will come up for you about how to test, what to test for, what the screening tests mean, where to refer to. It's fantastic. And this is the Melbourne one, but there are health pathway systems for regional areas as well. And they'll have a lot of local services at the end of it. Optimal Care Pathways comes from the Cancer Council of Victoria. And again, you can go into different cancers here. I guess you'd be going into liver cancer. And again, a whole lot of resources will pop up for you. Their cancer screening hub is full of information for your client group, really, more than health professionals, about hepatitis C and hepatitis B. There's a great little video here about Hep B in hip hop, so young people are going to be particularly interested in that. There's information in languages and information in plain language. There's a whole lot of links here for further learning and education. I particularly want to emphasise VITAL, the Victorian HIV and Hepatitis Integrated Training and Learning Program. They're a partner in today's presentation, and they provide free professional training on BBVs and STIs, and they also do the S100 hepatitis B prescriber training that GPs can do so that they can prescribe for hepatitis B. Even though any GP can prescribe for hepatitis C, they don't need to be an S100 prescriber. The service I'm from is the Victorian Viral Hepatitis Educator. Rebecca and I are based at St Vincent's in Melbourne, and we are funded by the department to provide tailored bespoke training to you, to your practice. So we can tweak it to whatever you need. We can come and do it in person. We can do it online. So there's a whole lot of information there for you, and opportunities to access further training, further support. Liver Well, again, the Eliminate Hep C project have all sorts of brochures for you. Here at St Vincent's, we have a lot of plain language resources for people with low health literacy who have hepatitis B and hepatitis C. There's a remote consult form for GPs who might be starting off with hepatitis C prescribing. You might want to have a little bit of support when you're just starting off. So this is a 2-page form. We just ask you to fill out some test results on it. It's not a lot of work to fill it out. You can then fax it to your nearest tertiary specialist clinic that listed up here, and we will, fax it back to you very quickly. I find that a lot of GPs, after they've done this 3 or 4 times, they feel a lot more confident to start prescribing by themselves. The PENCAS Screening and Management Guide is available to help you do your audits and organise your management systems. There's a lot of learning available on inclusive practice. So some of these, I mentioned the power of words, TeachBack and Hepatitis B video on how to actually use TeachBack. There's a lot of information there, so please access these, and I'm sure you'll find ways to improve your practice. I'd like to acknowledge all the services that have helped put this program together, and I hope to hear from you soon if you'd like some further training, and thank you for your time.